Spinal cord injury.
Those confusing that there's not
So, what is it? Damage or trauma to the spinal cord. There's all the big facts about why this is important, why we need to know it. There's 12,000 new cases each year. There's 260,000 Americans living with it. Who are they highest in? Who do you think?
elders.
Men. Those stupid men. No, I'm just kidding, y'all. Just kidding. They're the daredevils. Who are the people, who's out there like, let's see if I can go take this skateboard down the roof and twist around and jump into a pool. Yeah. So males, right? 81% of spinal cord injuries are males. And their ages 16 to 30. So, during the prime of their life.
That's when they have the most.
We are seeing an increase in older adults only because the mean age of people in general are increasing. So we used to, people used to die in their 40s or 50s. Now we're living much, much longer. So the mean age is increasing. All right, decrease mortality. So we have improved treatment strategies. We can take care of these patients much better. So these patients are living a lot longer. They're less likely to die at the scene because we're able to stabilize them. We're able to treat them. But there's lots of long-term issues. If 81% of these people with spinal cord injuries are between the ages of 16 to 30, that's like most of us right now, right? In this age group, most. So there's what's going to happen long term. Well, just say Disruption of growth and development. There are definitely altered family dynamics. What if you have someone, when I had both children before I was 30, so I was 30, and let's say I was a stay-at-home mom with my husband. What happens if he has a spinal cord injury, and now I'm a single or a stay-at-home mom with 2 children with no job, and we just lost our family's income? That's scary, right? And this is long-term. And then the economic loss, it's not just their economic loss because they can't do their job anymore. What if they got a spinal cord injury because they were a roofer, they fell off the roof, and now they have a spinal cord injury? Do you think they can go back to roofing? So they can't go back to their job, so there's an economic loss there. There's also an economic loss because do you think that the care for their health care is going to be very expensive? So there's multiple ways in which there's an economic loss. And 90% of these patients are non-institutionalized, meaning they go home. So they have to make changes to their home. If they're wheelchair bound, they have to have wheelchair access. If they lived in a 2-story house, they may have to move or, again, change the way in which they live. Just maneuvering around their house. How many of you have a house that would be compatible to get everywhere you needed to get in a wheelchair? Probably not many of us. So, causes. What do you think the number one cause is? Car accidents, yep. And then, that's supposed to be a V, it looks like a U. MVCs. And then falls. It's also because of violence. We see some spinal cord injuries because of sports injuries. And then miscellaneous causes. Huh? Like war. War. I would die laughing if that was a question. Yeah. I didn't make this one. I honestly haven't seen it. All right, so why? So there's an initial injury, that cord compression. And the cord compression is caused because either a bone has been displaced, there's some kind of interruption in the blood supply, there is traction from pulling on the cord, or there's been some kind of penetrating trauma. So a tearing of the spinal cord or transection, like a gunshot wound. Those are rare, but they do happen. So we have the primary injury, which is the initial disruption of the axons. So something happened to the spinal cord. A bone got displaced because they fractured it, the blood slide got kinked off, they had a gunshot wound, they had this initial disruption of axons. And then the secondary injury is this ongoing progressive damage. There's lots of theories on why this exists. They think that sometimes ischemia of the cord happens because they lose the blood supply, or that it could be almost like a auto disease where the body attacks itself because of free radicals. They have all these crazy theories, hemorrhage or edema. But there's several theories of why this secondary injury happens. So the primary is when they get hurt, and secondary is that response to the hurt. So we need to initiate care and management ASAP, because the quicker we initiate management, the less secondary injury there is. And most of the time, the extent of the injury and the prognosis for the patient is about 72 hours afterwards. So we don't know exactly the extent because it depends on how much secondary injury there's going to occur. Extent of injury / prognosis is most accurate 72 hours after the injury. For whatever reason, I always forget that when I make dossier, I don't get the watermark, but they put the watermark on there. So on my screen, I don't have that. Huh? Yeah, dossier. So mechanism of injury. How does it happen? Lots of different ways it happens. Like in the first example, they flex too hard. Flexion. They can have hyperextension. Yep, it's falling out of the chair and hitting their chin. So they hyperextend that neck fast. It's that kind of fast snapping motion.
Oh.
Mm-hmm.
Are you okay? Yeah, that just hurt like my
Compression. Those people that dive into the shallow ends, this is a lot of times what you see, they compress. Again, remember, it's because of some bone displacement. It's because of some loss of blood flow. You can have flexion, rotation.
I know.
This is the most unstable of all of them because the ligaments surrounding it are also damaged. So you don't get a stable spine at all. And then there's not a picture, but extension, rotation. So this is how we classify it. We classify it how they got injured, the mechanism. So they flex, so they hyperextend. And then we classify it by the level of injury. Is it skeletal versus neurological? And neurological is important to know because this is the lowest segment of the spinal cord where they have normal sensory and motor function on both sides of the body. So if at T5 they have normal motor and sensory on both sides, that would be your level of injury. Does that make sense? So you may have lower and only have motor and sensory on one, that's not the level that they're going to measure it at. They're going to measure the level of neurological injury at the lowest point where you have motor and sensory on both sides. Does that make sense? Okay. No?
I'm not sure.
Okay. So let's say you have an injury and you can move both your arms, and that's whatever T or C, whatever, C5 or T1 or whatever it is. So you can move both arms, you have feeling in both arms, that's where they're going to measure it. Now, you may have some feeling in your leg because that's a T12 injury, but they're not going to say that's your level of injury because they're basing your level of injury on the point where you have function and sensory on both sides. Does that make total sense? So you may have some function of your leg on the right side, and you may have, because there's different dermatones, there's different nerves, so they lead different ways, and we're going to talk about complete versus incomplete, which is the degree of injury, in just a minute. But so you might have little neurons or pathways that have stayed intact, so that you have some little motor function in your toe, or you feel your knee on your left side. But that's not where they're going to measure their level of injury. They're measuring the level of injury at the highest point where you have both motor and sensory function on both sides.
So is that like the classification?
That's the classification. These are all classifications. Mechanism of injury, level of injury, degree of injury, that's how we classify it. So we would say that if they had a spinal cord injury, it's a flexion injury, and their neurological level is at T whatever, because below that level or above that level, they have full motor and sensory function.
Okay, got it.
All right. And level, they can either be what we call a tetraplegic, which used to be a quadriplegic is what they used to call it. Now the term is tetraplegic. That's typically a cervical injury. They have lost all motor and sensory function of all four extremities. Or it can be thoracic, lumbar, and sacral, where they have, those are paraplegics, where they lose motor and sensory function of the legs.
How did you spell that word in the
Tetraplegic, Tetraplegia. That's what we used to call quadriplegic. Mm-hmm. And like we said, the degree of injury can be complete, where there's a total loss of sensory motor function below the level of injury. Yes, ma'am.
If you are like a tetraplegic, do you lose like respiration?
Yeah,
function
we're going to talk
and
about that.
everything?
Mm-hmm. Yeah. So complete means total loss. Where incomplete means that there's a mixed loss of voluntary motor activity and sensation. So it's those dermatones, those tracts. Some of them remain intact. And so, like I said, you might have where they can feel, I don't know if you've ever taken care of a lot of patients with spinal cord injuries, but let's say that they are a tetraplegic. So they have no use of their arms and legs, but if you touch their third left toe, they can feel it.
So with the incomplete, they could have sensory on one side and motor on the other?
Yep, just depending on what dermatome, what tract stayed intact. But we know that it's either complete or incomplete. Now it can be incomplete, and we base it off the level where they have function on both sides, their neurological level. Does that make sense? These are all the ways to classify it. How they did it, the level of injury, and the degree, whether it's complete or incomplete.
Would you say complete is symmetrical, incomplete?
Yes.
Not symmetrical?
Yep, complete is symmetrical, meaning that everything like below whatever, everything below T1 is done. Incomplete means that there's some tracts intact. So clinical manifestations, these are related to the level and degree of injury. Obviously, if someone has injured their cervical spine, they've lost all function from below. But if they've only fractured at T12, they still have control of respiratory and heart. So we're going to get into each of these. Incomplete is obviously more variable because we don't know what tracts have stayed intact. And obviously, the higher the injury, the worse the outcomes. So, respiratory. What's your name? What's her name?
Caitlin.
There you go, Caitlin. Respiratory. All right, so respiratory, and leave some space because we're going to come back to these. We're going to do clinical manifestations first and come back and put treatment underneath. So if it's higher than C4, so C1, C2, C3, higher than C4, they have total loss of their respiratory muscle function. These patients require mechanical ventilation. If it's lower than C4, C5, C6, what they get sometimes is that diaphragmatic breathing. They can't use their diaphragm all the way. So a lot of times they have respiratory insufficiency. In general, all cervical, and everyone understands cervical, thoracic, lumbar, correct? I know that sounds silly, but I just want to make sure. All cervical and thoracic injuries, they have some paralysis of the abdominal and intercostal muscles. So if they don't have great control or paralysis of their abdominal intercostal muscles, what can't they do? Cough. Who said it? Get gold star, Wendy. Cough. They can't cough. If they can't cough, what's going to happen? Pneumonia, or they develop atelectasis. Oh, you guys are so good. This is why you guys made it to level 4. And if they have atelectasis, pneumonia, they're at increased risk of infection, right? They can't move those secretions like we do. How many times do we sit here and clear our throat, or if we feel something, we cough it up? They don't get that. And they can also develop pulmonary edema. So if it's higher than C4, they definitely require mechanical ventilation. If it's below C4 and involves thoracic, a lot of times they have respiratory insufficiency, they don't have a great cough, they're at way higher risk for infection, atelectasis. Cardiovascular system. So if it's higher than T6, so cervical, T1, T2, T3, God bless you. They get decreased effect of the sympathetic nervous system. And Ms. Schneider's going to lecture you guys for your cardiac next, but sympathetic raises heart rate, parasympathetic lowers it. So if we have loss of that sympathetic nervous system, what's going to happen to your heart rate? Decrease, right? Because sympathetic helps maintain our heart rate up. So if we lose it, our blood pressure or our heart rate is going to drop. So we get bradycardia. That sympathetic nervous system can't function right. It can't control the heart rate. Sympathetic nervous system also helps with constriction to help keep our blood pressure up. So if we don't have that control, we get this peripheral vasodilation and hypotension. Mm-hmm. Well, no. These are clinical manifestations. No, that's going to be a complication. We'll get there. Hold it. Stop. And then they've got all these dilated veins, right? So if their blood pressures drop, what do you think is happening to their fluid status in general? Decreasing. They're becoming hypovolemic. No, these are all just clinical manifestations broken down by system. So we're talking respiratory, cardiovascular, urinary. They retain urine, urinary retention. What happens to your bladder if you retain urine? It gets distended. What happens if you have a distended bladder full of urine? Where does the urine start to go? Back to the kidneys. That's right. What happens if urine goes back to the kidneys? infection and renal failure, right? All right. Does someone need me? I'm sorry. Someone say excuse me? No? Am I crazy?
Are there,
Oh, okay.
Are there gonna be 2 arrows?
There are going to be 2 arrows.
Yes. I just wanted to make sure. for my
You're starting to get my shorthand down. So they get over-distended bladder, they get reflux to the kidney, that kidney starts to fail. And then or the bladder could just rupture, period. Which is probably no bueno.
Sounds like such a relief.
Not if you have urine floating in your belly. And then someone said it with urinary retention, we're at risk for infection, so what do we develop? UTIs, yep. You really want your patient to be septic, don't you?
I do.
Savannah's just going. Oh, did I call you Savannah? I'm sorry, Savannah.
That's me.
Haley. Sorry.
There you go.
All right. In addition, long term, they're going to develop a neurogenic bladder. With this, they get urgency, frequency, incontinence. They can't void because the nerves to the bladder can't regulate it. Again, they get that high bladder pressure and they can reflux to the kidney. GI,
So it damages the nerves of the bladder, so you can't.
well, the nerves to the bladder. So they lose that, remember, because everything below from the point of injury is they can't control anymore. So just like they can't control their muscles, they can't control the muscles that squeeze and release. So they have no control over that. So that's where that neurogenic bladder develops.
So it's not caused by the, oh, sorry.
Yeah, we'll talk about that in a second.
It's not caused by the overdistension though?
No, that's something separate. They get over distended because they're not, yes. All right, so especially with injuries greater than T5, you get hypomobility. Again, we don't have control of those muscles, so it's not just the muscles that move your arms and legs, it's the things inside your body too. So they get hypomobility with the paralytic ileus, gastric distension. And can they tell you that their belly hurts? No, they can't feel it. This is every patient that's in the hospital develop stress, and all of you. Stress ulcers. If the injury was a gunshot wound, or if they had a tearing, they're at risk for intra-abdominal bleeding. And just like with the neurogenic bladder, they develop a neurogenic bowel. Again, because they lose that function to control the muscles, to feel. So they often develop constipation.
What about like impactions?
I still don't wanna do it.
Skin. Skin breakdown. You said it. They're not moving around, right? They can't move around. So areas, especially over any bony areas, are going to break down. And then this, I'm going to butcher the freak out of this. How do you say it?
Poikilothermia.
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 Yeah.
Can you spell that out loud, please?
Poikilothermism.
Is that specifically to higher than T5
No,
or
no.
just skin?
Yes, skin in general. So what this is an again, we have this interruption in the sympathetic nervous system. So these patients aren't able to sweat or shiver. They don't get that sympathetic nervous system response. So it, below the level of injury. So whether it's C1 or L12, there's no L12, L5, they cannot sweat or shiver below the level of injury, okay? So they can't regulate their body temperature. They become like alligators.
Alligators can't regulate their body?
Aren't they cold-blooded or something? They have to like, I don't know, go back to Will Smith's concussion movie. But they can't regulate their body temperature. And the degree depends on the level of injury. So it's way more common with cervical injuries because obviously if you have a cervical injury and you can't control your body temperature from neck down, that's more significant than if you can't control your body temperature from waist down. Does that make sense? So this is all dependent on where the level of injury is because the symptoms are below the level of injury.
This is the one where if they're put outside and the temperature's up, their temperature
Yes.
will go up. If they're put somewhere cold, they'll-
Like an alligator.
Okay.
I can stay.
Yes, Raydell.
I had to
Cold
take
blood.
care of a patient once, who, to the best of my knowledge, was a tetraplegic, no arms, no legs, had to lift and that.
Uh-huh.
But he had the feeling that he was cold all the time, even when he wasn't, and so he'd ask me for blankets upon blankets. And then he would sweat like
Yes.
a lot. So,
That's this.
yeah.
Because he can't. So his feeling may have been phantom or whatever, but he had no way of controlling. He technically could not feel the hot and cold. They have no sense of that. But so they can't regulate that body temperature. But if you put 400 blankets on top of them, they're gonna overheat their body.
So, like, in his particular case, like, he wasn't consciously sweating, but his body still did it.
Yeah, because his body's still getting hot. You just put like 100 blankets on him, he's gonna get hot. And we're gonna talk about that in treatment because you have to be very careful about not putting too many blankets on them or being careful when you expose them to air.
Because we all do that. Like the electrical, like the blankets.
Metabolic needs. These.
With the skin, so does that even mean like with the temperature of the water, like in the
Yep.
showers or the bath, like they can't feel if it's too hot?
Yeah.
Oh.
So, and metabolic needs, these patients are getting suctioned a lot. And if we're putting out a lot out of our GI, we develop the metabolic alkalosis. And they get lots of altered electrolytes like sodium and potassium. They often get a weight loss greater than 10%. Especially sodium and potassium. And they become anorexic. They don't want to eat. Things don't taste good. And it's a lot of times they've lost control of everything, especially if they have become a tetraplegic and they can't move. So food is the one thing they can control. So they'll use it and they won't eat because they can control that.
Does that say more than 101?
More than 10%.
10%.
You can't lose more than 100% of your weight or you won't be around.
They just read 101 pounds.
That's what I
thought. Oh, I'm sorry.
10,
I was like, wait.
greater than 10%.
101 pounds.
Peripheral vascular. So if they're not moving, the blood becomes what? Stagnant, right? You got this circulatory stasis. What develops? That's right, DVTs. If these clots become dislodged, what happens? Embolism, PE. And that's the leading cause of death for them. Because they develop these DVTs, we sit there and move them all around, dislodge them, and they develop a pulmonary embolism. Because again, they can't tell you a lot of the symptoms that we look for. Musculoskeletal, they have a lot of instability. So at the level of the injury, they're very unstable. So we need to be very careful to prevent any further injury. Muscles, what do you think their muscles develop? Yeah, atrophy, but also spasms and contractures. If they're not using those muscles and stretching them out, sexuality. I'm sorry, what? Oh, yeah. So, yeah, you guys are gonna make me blush now again. Males, they develop obviously erectile dysfunction. And they can develop priapism.
Look, she turned red.
I know, don't. Females, they get lubrication issues. But the big thing, especially for females, is they remain fertile. I know that seems silly, but people think that because below the level of the neck doesn't work, that me and my boyfriend can still just do it, or me and my husband or whoever can just keep having sex no problem with no protection because it doesn't work. But just because the nerves doesn't work doesn't mean that your hormones, don't work. Your hormones are still releasing eggs and they're still fertile. And they get pregnant, and then they're like, well, how did that happen? They can still menstruate, yes. So, but they don't get all the symptoms. So, a lot of times they don't think about that. So, if a female has a spinal cord injury, it's like they forget that they can still be fertile because they think everything's broken from below. But you remain fertile.
What if they do become pregnant? Like, does it just depend on the location of the injury?
No, they still can. They can carry a normal and have a normal pregnancy.
They would have to have a C-section.
We're going to talk about that in treatment, but yeah. So psychosocial, remember, they have a sense of loss, and it's not just for the patient themselves, but it's for the family too. They feel a great loss of control. They are no longer independent. They have to rely on others significantly. There is a wide fluctuation of emotions. They are angry, they are sad, they get depressed. And this is not so much an acceptance, but an adjustment. And I think that's where a lot of people that they say, they just need to accept. No. It's hard. They may never really accept that they had this loss. They had their legs and they were working and now they don't. But they do have to make adjustments. So complications. Here you go, Janice. This is your complication. Spinal shock. This happens in about 50% of patients. And it can last days to months. So this happens because there's this period of time where you have all this bruising and swelling around the injury. And because you have this, just like anytime you have any injury, there's that initial inflammation, the body's rushing to repair itself, and you have all this bruising and swelling around the injury, and basically signals can't get past it. So we don't know if it's a complete injury. We don't know if it's incomplete because things aren't getting past this area because of the bruising and swelling. And it may take just a few days or it may take months. So when we look at this patient, the clinical manifestations below the level of the injury, they lose all their reflexes. They have a total loss of sensation. And they have a flaccid paralysis. So we can't really tell their full extent of their injury because this may make it seem like it's worse. We can't tell if it's a complete injury because there's all that bruising and swelling. So there's this disruption in the communication between the upper neurons and the lower neurons. They can't get through. Once that bruising and swelling decrease, there actually may be some communication they may develop some reflexes or sensation that they initially didn't have. But with the spinal shock, again, about 50% of the patients, because of the bruising and swelling, that communication gets disrupted and they have loss of reflexes, loss of sensation, and the paralysis.
Is
Yes.
that why sometimes patients can like walk again after?
So it can't cause further injury, that inflammatory process.
Yeah, it doesn't cause further injury. It's like your body's in shock right now and it's not communicating. So it can sometimes make it seem worse. You can't tell if it's a complete loss or it's an incomplete when you're classifying it. Does that make sense to everybody? Other questions? No? All right. Then another complication is neurogenic shock. And this is due to, they lose that vasomotor tone. And it's normally with a higher level injury, so greater than T6. And it's what we've been talking about with these T6 or greater injuries. It's that loss of the sympathetic nervous system. So we talked about like cardiovascular, they vasodilate, they get venous pooling, and they drop their cardiac output. So it's the symptoms, the clinical manifestations we've already talked about, hypotension and bradycardia. I can see that's why Janice, it's similar. But they also have warm, dry skin below the level of injury. Why? Because the pooling, right? They've got all this vasodilation, all the blood's going there. They get this really warm, dry skin below the level of injury.
Decreased carbon dioxide, that's what that last black is here.
Cardiac output. Decreased cardiac output. Because if everything's pooling, right? You got all this venous pooling, it's not coming back to the heart. Do you have enough blood to go back out? So your blood's not getting hard to get it back out. So your cardiac output drops. Another more serious complication is the autonomic dysreflexia. And this is a massive, uncompensated cardiovascular reaction. And again, it's all mediated by the sympathetic nervous system. The parasympathetic nervous system can't counteract these responses. And this is life-threatening.
What does it say?
Massive, uncompensated cardiovascular reaction mediated by the sympathetic nervous system, SNS. And it's largely due because the parasympathetic nervous system, the PNS, is unable to counteract the effects. And it's life-threatening if it's not treated.
Could you give like an example of what you mean right
Once I keep going.
there? Okay.
So typically after spinal shock resolves and the reflex start to return, this occurs, and they get a distended bladder or rectum because in the initial, remember, they don't have control of their bowel or bladder anymore. Somebody forgets to cath them, or we don't realize that they're constipated. And so the sympathetic system kind of starts responding, and the parasympathetic isn't balancing them out. Or they get stimulation of the skin, or they have a pain. So anything that activates that sympathetic nervous system. So spinal shock is kind of resolved, the reflexes are returning. You have this sympathetic nervous system that's kind of going crazy in response to your over-distended bladder or your over-distended rectum, or they have pain or someone's stimulating their skin. And the sympathetic nervous system is responding, but the parasympathetic can't counteract it to even it out. So they get really, really bad hypertension. Like their systolic blood pressure will go up to 300. This is why it's life-threatening. and their heart rate plummets. It goes down to like 30 beats, 30 to 40 beats. They obviously are going to have a throbbing headache if their blood pressure is 300. And they are very diaphoretic above the level of the injury. They're also going to be flushed above the level of the injury. They're going to complain of blurred vision, nasal congestion. Just think everything above is just being engorged with blood. Because that pressure is so high. They can complain of nausea, and obviously they're going to maybe be a little anxious. So if you go in there and you notice your patient's blood pressure is high and they're bradycardic and they have a spinal cord injury, you're going to think, oh crap, this autonomic dysreflexia might be happening. So what's the first thing you're going to do is put that head of the bed immediately up to at least 45 degrees. And then you need to stop the cause. So what causes this? An overdistended bladder, what are you going to do? Cath. Straight cath them right away. If it's because they're constipated, what are you going to do? Yeah, impact them, so they may have to do a digital rectal exam. Get up in there, get it out. Because your patient is going to, I mean, honestly, it's very life-threatening. If we don't stop what's causing it, then they're going to continue to have elevated hypertension and they're just going to stroke out. If it's because of skin stimulus, we want to remove anything that's stimulating the skin. If it's because of pain, we want to treat the pain. You need to monitor the blood pressure, and obviously we need to start giving blood pressure medicines like alpha adrenergic. That's what they say. Alpha adrenergic. Adrenergic blockers. And then patient and family teaching. But the main thing is get that patient up, because we want that, because remember, everything that, because of the hypertension, you're getting this a massive amount of blood up here. So you don't want them laying back where it can just keep flowing. You want them up to let gravity work with you, and you want to remove whatever stimulus is causing it and treat that blood pressure.
Do they know what causes the PNS not to be able to counteract?
It's because of the disruption of the nerves. And they don't, so you have wherever the level of injury is, and like we said, there's complete and incomplete, and some tracts, dermatomes remain intact, and some don't. And typically, if you have a T6 or higher, that's affected. The SNS and the PNS are affected by that. They just can't regulate because they're not able to control the muscles and nerves like they
So
did.
then once those reflexes start coming back, that it like overwhelms the system.
Yeah.
Could you read the etiology for the first, like, what's that P of the line number?
After. So after spinal shock is resolved and the reflexes return, it kind of, so you were compensating, and then all of a sudden your reflexes return, your sympathetics kind of going crazy, can't respond, everything's just out of whack.
When you said to like raise their head of the bed, it made me think, so if they're paraplegic and they can have use of their arms, are their blood pressures going to be different in their legs than in their arms?
It could be.
So is that something that we would like, is that a normal nurse check?
Yeah, and you would want to monitor both.
Okay.
I can't remember what level it was, but when the autonomic nervous system is like, is it destroyed in your bradycardia, or is it just altered and that's why we have?
It's altered and it's not responding the right way.
Okay, so it's not, that's why you're not doing this. And also, can we do a cath and digital rectal exam without notifying the physician, or?
I would imagine there would be.
I think there's like there's typically standing orders with spinal cord injury patients that like cath over whatever. Honestly, if your patient's truly experiencing this and you cath, no one's gonna like fault you because that's what's causing it. Yeah. Any other questions?
So would you do like a bladder scan first, or you? would
No, I would
just
just cath. Because it's the two main causes.
First training would be.
Yeah. Now, if you cath them and you realize they're not impacted, and you're like, okay, what's the next thing? That's when you start going to your other resources.
You can palpate a distended bladder.
Yeah.
If they feel it.
But if your patient's blood pressure is 300, I just want to. All right, diagnostics. So obviously, a CT scan is going to be your gold standard. That's what's going to tell you the level of injury, where the bone is messed up. You can do cervical x-rays. They're not as great. CAT scans are much more specific. MRIs. Again, what's our immediate goal? First thing. Airway, right? Patent airway. And then ventilation and O2. So they just had the injury. They're coming to you, they're new. Our immediate goals are to make sure they have an adequate airway, because what if it's a C3 injury? What are we preparing to do? Intubate. What if it's a C5 injury? Do you think that they're going to have adequate respirations? We might have to augment that, right? We want to make sure there's adequate circulating blood volume. We want to keep that mean arterial pressure greater than 90, control any bleeding. And remember, we want to prevent any secondary injury. So we want to prevent further core damage. Stabilize the C-spine, get IV access and imaging. We want to know right away, get those CAT scans. So stabilize them, get those CAT scans, see where our injury is. Ongoing, we're going to monitor their vital signs, right? Especially like we talked about, blood pressure, their temp if they can't auto-regulate, their urine output. We don't want them to get a distended bladder because we don't want them to develop the autonomic dysreflexia. Their level of consciousness. We want to keep them warm. Monitor urinary retention, hypertension. And do a thorough assessment history on the patient. This is when we get really specific and see exactly where they can feel, what they can move, what they can do. How did it happen? We want to know those classifications of a spinal cord injury. We want to know the mechanism. We want to know where they're having feeling. We want to know if it's complete or incomplete. So if we go back to the respiratory system, I always do clinical manifestations in green, treatment in blue. So, how are we going to treat based on the respiratory system? We need to monitor their breath sounds, blood gases, ABG, their breathing pattern, and their color of their sputum, because if they are not having a great cough and they're at risk for infection, the first thing that might tell you that they're developing a pneumonia is that their sputum color changes. And you guys are at the bedside, so you're going to be the first ones to notice this. So how do we help make sure that these patients don't develop atelectasis or pneumonia? CPT, right? We talked about that a lot with CF patients. We want to move those secretions. It's that the chest physiotherapy. In the old days, we used to cup them. Now they have vests. I'm sorry, what?
Is it like the cystic fibrosis treatment?
The what?
Nothing? For cystic fibrosis?
Yes, it's the same thing for cystic fibrosis. Yeah, because their secretions are just going to sit there. They have this ineffective cough. They can't move secretions. So we need to help move them for them. So chest respiratory will come in and do chest physiotherapy with them.
What's IS?
Incentive spirometer.
Oh.
They may need, now maybe they have a low thoracic injury, so they cough, but they don't cough great. So they may need to be taught how to augment your cough. We talked about that also in level 3, where you push on the diaphragm as they cough to make sure that it goes all the way up. They may have to teach a family member to help that patient that twice an hour they have to do an augmented cough, or they do it to themselves where they lean up against something and cough so that it forces it up. So they just may need to learn alternative methods to have a more effective cough.
Anything in the C levels is gonna affect breathing,
Well, C, yep,
and then anything in the thoracic is pretty much gonna be from their like,
diaphragm, because thoracic is like here.
right, well, like, is
Yeah.
that gonna affect their like urinary and stuff like that, or is that, no?
T6 and below, like urinary, bowel, everything.
Okay.
But again, it also depends on whether it's complete or incomplete. Some tracks may remain intact, but. And then lots of patient family teaching. Cardiovascular, if they have a low blood pressure or they're bradycardic, medicine we can give is what? It says it. Atropine, right? So if their heart rate drops below 40, we want to get that heart rate up, right? We want to make sure we keep the body perfused. The way we keep the body perfused is by keeping blood pressure and heart rate up. So if the heart's not beating fast enough, we need to get it going. Atropine. Sometimes, if there's enough damage where, like, it's a higher level injury, they may require a pacemaker because the body's never going to send the right signal to keep the heart rate up. That sympathetic nervous system's been disrupted enough that they will always need help. And you can't give atropine forever. So what if they have hypotension? What do you think we're going to do? Fluids, good. What else? Sometimes in the short-term period, what do you think we're going to give, medicine-wise? Pressors, someone said it. Vasopressors, like dopamine. Huh? In addition, we're going to obviously monitor them cardiac-wise. Vital signs. Why do you think we're going to monitor their hemoglobin hematocrit? Bleed, right? If they're bleeding, they're going to become hypovolemic. If they're hypovolemic, it's going to make the hypotension and bradycardia worse. And again, they can't really tell you that, oh, my belly hurts, I have a bleed in my belly. So sometimes the only way we can tell is by monitoring their vital signs or hemoglobin hematocrit. And no vagal maneuvers. What does the vagal do to your heart rate? Drops it. So do we want to be like turning them all around, suctioning them, going crazy? No. Because they're going to become even more bradycardic.
What's vagal? I thought that's not bearing down, that fell down, or what's vagal?
Kind of like, yeah. Or suctioning. Yes. All right, urinary. UTI. So these patients require a cath. We do it, initially they may require an indwelling catheter, so especially so we don't have any problems with the autonomic dysreflexia, but long-term we want them to be intermittent. Why? Infection, yeah, because anytime we leave anything in the body for a period of time, it increases the risk of infection. So we make these patients intermittent cath as soon as possible. Sometimes they do the condom caths if they can. And they're cathed frequently, every 3 to 4 hours, so that they don't get that urinary or the bladder distension, because that's going to put them at increased risk for the reflux and kidney failure. And you're going to monitor for any signs and symptoms of infection. They don't complain of pain. They don't feel like if you've ever had a UTI and you get that suprapubic pain or you get the kidney pain, they don't feel that. So they can get a pyelonephritis really fast without you knowing if you don't treat or if you don't monitor them. So chills, fever, malaise. Aseptic technique is really important, and to teach your patient aseptic technique. They're sticking a catheter in their body several times a day. You have to make sure that they're doing it so they're not going to increase the risk of infection. Check the patency of the tube, especially if they have an indwelling catheter in the beginning. They can get kinked off, and then, so let's say you have that patient with a spinal cord injury. It's day 3. They have an indwelling catheter still because, for whatever reason. And you notice their blood pressure is going up. You're concerned for autonomic dysreflexia, but you're like, I've got a catheter in. Check the patency. It may not be draining, so they're getting that urinary retention. And then make sure they're getting enough fluid so that they're flushing out their body. Neurogenic bladder, they might need anticholinergic drugs like ditropan. This suppresses the contractions. They might get the alpha adrenergic, oh my goodness, thank you, blockers, which relax the smooth muscle. Antispasmodics, which I think is self-explanatory. They stop spasms, like baclofen.
What is the thing before adrenergic blocker? Alpha.
Or they may even get urinary diversion surgery. Has anyone ever seen where they put, urostomies on the outside, very much like a colostomy. They divert out to the outside of the skin, and they can actually cath from the outside, which is pretty cool. You need to make sure that these patients have really good referrals and good supplies. Don't send them home because they're going to be cathing themselves frequently. They need to make sure that they know where to get their supplies, how often to get them, that insurance is going to cover them. The last thing you want to do is hear, and it's sad, you hear this patient that's like, oh, I just rinse off my catheter and I reuse it every time. Yeah. Yeah, and it puts them at high risk for infection. So GI, if their belly's not moving, they get that ileus, they get the gastric distension, they can't tell you. We need to put an NG tube down and decompress their stomach. Maybe start Reglan. Does everyone know Reglan kind of gets things going, gets things moving? We talked about stress ulcers. What do we use for stress ulcers? PPIs, H2 blockers. Every patient in the hospital is in one of these. They're bleeding. They can't tell you that they're uncomfortable or that they feel full or that their stomach's getting bigger. But you can monitor their blood pressure. What's going to happen to their blood pressure? It's going to drop. The hemoglobin hematocrit going to drop. You should also be doing abdominal girths on these patients. So if they shouldn't have changes in their abdominal girths.
Would they have like change in their stool color too?
They could, but not necessarily, because it fits outside the colon or the intestines. These patients need to be on a bowel program. They need to sit on the toilet at a certain time every day, record their output so that they don't, oh God, I haven't had one in 3 days and I forgot about it. Unfortunately, they have to keep a better record of it. They may need some kind of rectal stimulant or suppository like a glycerin. This is where nutrition becomes important. They need a high fiber diet, lots of fluids so they don't get constipated. And they may need stool softeners like Colace. Now, oral laxatives like Miralax or those type of things, you don't want to use those regularly. If they're having to use that a lot, then we need to make some kind of dietary changes for them. Colace you can use to soften, glycerin you can use, but we don't want to do a bunch of oral all the time if we don't have to. Just because it can make changes in their electrolyte imbalance. Yes, ma'am. Don't use regularly.
Miralax can make changes in their food like that.
If used long-term and in massive amounts, yeah. It's not as bad as some of the others, but don't freak out about your son. He's okay.
How do you know?
So skin, if we're worried about breakdown, we're gonna expect, and not just visually, but we wanna touch their skin too. Because a lot of times you may not see the beginning of a breakdown, but you'll maybe feel an indent over that area or feel that the skin has changed in texture over that area. They need to be repositioned at least every 2 hours, especially initially. They have special mattresses, special chair cushions. Protein is important. We can monitor their nutritional status by monitoring prealbumin and albumin. And this is where we're talking about protect against thermal injury. So they can't feel, if you put them in a hot bath, just like a baby where you have to check the temperature, they can't tell you that it's too hot or too cold. And if they can't regulate their temperature, you could put them at serious risk, especially, like I said, burns. Thermal injuries are really prevalent because they spill coffee on them and they don't feel it, or they are making themselves hot tea and they touch the kettle and they have no idea they touched it. So because they don't have that sensation. So it's really, really important that you educate them and protect them against any thermal injuries. You want to monitor their environment and monitor their body temperature regularly. And like we were talking about, Raydell, you don't want to overload them with blankets. Or like if you're giving them a bath, you don't want to just strip them naked, just sit them there and like putting cold water all over them, because they're going to lose, their body temperature will drop significantly and fast. So you'll keep them covered and only wash the area that's exposed and then cover them up. Just for a second, because we're running out of time. And this will all be recorded, so you can go back to it. All right, so monitor fluid and electrolytes for the metabolic needs. Again, weight loss, high protein, high calorie diet. Especially for a higher cord injury, evaluate their swallowing. Don't just assume that because they have a T3 injury that they can, swallow normal. They may need to change, get thickened feeds. Like Caitlin was saying, if they can't eat by mouth, they need to either G-tube feeds, they need TPN, they need their nutrition. Supplements, high fiber diet. Again, they become anorexic because they want something to control. And oftentimes this is the only thing that they have control over anymore. So you want to address the reason. Talk to them. Why don't they want to eat? Is it because the food doesn't taste good? Maybe their tastes have changed because things have changed for them in general. You want to make a contract with the patient. I know that sounds silly, but a lot of them, if you make a contract with them and say that they're going to eat this many carbs or proteins or whatever, or this many calories per day, and they make it a really good eating environment. Make eating fun. Because unfortunately, and I know this sounds horrible, but their life sucks all of a sudden. They just went, and imagine a male, 20-year-old male, strapping young college student who was at a party drinking, and he decided to dive into the pool, and he was going to school to be a doctor, and he was fun, and he had lots of girlfriends, and he was going to football games, and now that's all taken away from him. He's pissed and angry, and whatever we can make good in his life, we need to try. And that's especially with eating, because they lose complete interest in that. DVTs, this is really important because what's the leading cause of death? The pulmonary embolism, right? Caused by the DVT. So SCDs are really important. Range of motion exercises. We don't want that blood to remain stasis. We want it moving, circulating. So the compression devices help to get the blood flow back up. We want to keep them moving, range of motion. We get physical therapy and occupational therapy involved. And then it's really important that you as the nurse assess their calf and thighs. If you notice any deep red color or edema, they don't complain. Normally, what's the first sign of a DVT? They get pain, correct? Are they feeling that? No, so they can't tell you that it hurts there. But you can see if that area becomes reddened.
Wouldn't it be warm as well?
It could be warm. But if they're not really measuring, if they're not, their body temps are kind of out of whack, it's not as accurate. Musculoskeletal, you need to make sure these patients remain properly immobilized, whether it's the C-spine, whether it's skeletal traction, braces. Kinetic therapy is on a bed where the bed moves, but the patient doesn't. Have you guys seen those? Yeah. But big thing for them is log rolling them. Trying to keep that spine aligned and log roll them so that we don't cause any more disruption. We talked about baclofen for spasms and range of motion exercises for contractures. Sexuality. Educate these patients. Teach them about alternative methods. And I know this is silly and everyone gets giggly when we talk about this kind of stuff. But, their sex life is very important to them, especially if they have a partner. You can teach them alternate methods, oral sex, different sex, how they get aroused, that it's not just always about touch, that maybe their partner has to use words to arouse them. There's vacuum devices, they may need Viagra, and don't be embarrassed about it, that this is just a different way for them to interact with their partner. Sometimes there's surgical procedures, but I don't see that a lot. Obviously, teach birth control to females because they may think that they won't get pregnant because they're not, and they need to use lubricants. And then we were talking a little bit, pregnancy, they don't feel their contractions. So a lot of times they go into labor and they have no idea and a baby just pops out between their legs. So they really need to be careful about an unexpected birth because those can be really scary. So they are often checked more often. They get very good prenatal care. They may get a scheduled C-section earlier because they don't feel that, And just always use medical terms. Be, upfront with them. Don't be all giggly, don't make it a shameful thing because it's an important aspect of their life that people overlook and they go home and they don't realize that there's other options for them. All right, psychosocial, it's always important to maintain hope. Allow them to mourn. And it might take a while. So if they're saying, this sucks so bad, yeah, it does. Don't be like, it's going to be okay. Counseling. They may need drugs. Not like, they may. I don't know. That's up to them. But like antidepressants. Support groups are really important. They want to be with people who have the same loss as them. This is a little bit different, but like when I lost my mom, I didn't want to talk to people that had their mom. I hated them. And there were people that I didn't know very well that had lost their mom that became my best friends because they understood how I was feeling and what I was going through. So that's what they want. They want those people. And so support groups are really helpful. Sympathy is not helpful. They don't care if you feel sorry for them. They don't want you to feel sorry for them. All right, I'm going to go through these nursing diagnoses kind of fast because I know we ran out of time. I'm sorry. And again, they'll be on the recording. So they can have ineffective breathing pattern related to respiratory muscle fatigue, neuromuscular paralysis, or retained secretions. You might as well just come back to the recording because I'm going to go fly through these. All right. Impaired skin integrity related to immobility, right? They're not moving, their tissue's not getting perfused the same way. Obviously impaired urinary elimination because of the spinal injury, or they're not taking enough fluids, constipation. Again, neurogenic bowel, they're not getting enough fluids, they're not mobile. Risk for the autonomic dysreflexia. So these are our goals, and these are kind of important. We want them to have the optimal level of neurofunctioning. We want minimal to no complications of immobility. We don't want them to have pressure ulcers. We don't want them to have contractures. We don't, all the other things that can happen when we're just not moving. We want them to learn skills, gain knowledge, and acquire behaviors to care for self. A lot of times they get really depressed and they just say, take care of me. So we want them to do as much as they can to take care of themselves, to gain as much independence as they can. And we want them to return to the home and community. Remember that this is complex, lifelong. This is not something that we're going to fix overnight in a month. They're going to have to deal with this the rest of their life. Again, our goal is to function at the highest level. It's interdisciplinary. There are so many people involved. Physical therapy, occupational therapy, speech, neuro, I mean, you name GI, GU, they're all involved. Yeah, respiratory, they're all involved. And we need them all involved. It's always organized around the patient's goals and needs. Because remember, we want to maintain hope and we want to motivate them. So if their focus right now, and it's realistic, is to do this for themselves, focus on that. Because that's what's going to keep them going. The patient's expected to be involved, and we need to encourage them frequently. And evaluation, last but not least, we know we've done our job if they're ventilating adequately, if they have intact skin, if they have good bowel and bladder management, if they don't develop autonomic dysreflexia, and they have no complications of immobility. All right, I know we went fast at the end, I apologize. There was a lot of material to recover since we lost yesterday. Again, all of these will be posted to the class site